Okay, so I think we're good to start. Welcome, everybody. My name is Kumar Murthy. I'm the director of the Fields Institute for Research in Mathematical Sciences. I hope for many of you, this is a repeat visit and you're familiar with the Fields Institute, but for those who are new, let me just say a few words. We're an independent research institute doing research in the entire span of mathematical sciences, from fundamental research to applied and even industrial research. We're an independent nonprofit organization. We have about 20 universities as members. We're funded by the federal and provincial governments as well as several foundations. Fields has always been involved in research connecting mathematics to public health and disease modeling for some time through the Center for Disease Modeling at York, the Center for Mathematical Medicine at Waterloo, and also the lab on the mathematics of public health also at York. From an early stage in the development of this pandemic, Fields, together with its sister institutions, the Pacific Institute for Mathematical Sciences in Vancouver, the Centre de Recherche Mathématique in Montreal, the Atlantic Association for Research in Mathematical Sciences in Fredericton, together has taken a role in putting together a national task force to study the mathematics of COVID-19. And this task force has been both doing good research in the mathematics of this pandemic, but also in guiding and advising policymakers at the federal and provincial levels. Besides that, it's also important to communicate with the general public because there's a great appetite, I believe, for knowing what's going on about the pandemic and how one might look at it and what the role of mathematics or what the role of modeling is in all of this. So I'm absolutely delighted that the organizers have put together this wonderful event. It's meant to be very informal and that an opportunity for experts to reflect on this, but also for all of you to interact with them. So I hope you do that. I again congratulate the organizers for putting in a rather eclectic panel and also eclectic moderators who will guide you through this. Once again, please enjoy the event and do give us feedback on the event after it's over. Welcome to the Fields Institute and to the event. I hand it off now to Jude, who will take us forward.
Thank you so much, Kumar, and thank you for the introduction and for being willing to use the center to host this. We really appreciate it. Good afternoon, Canada and friends, family, colleagues, educators, and lifelong learners. Welcome to this Café Mathématique on mathematics and COVID-19 webinar hosted by the Field Institute. Bon après-midi, Canada et amis, famille, collègues, éducateurs et étudiants du monde. Bienvenue dans ce Café Mathématique sur les mathématiques et COVID-19. This is a webinar where Canadians and their friends around the world can hang out to have a conversation about mathematical modeling, specifically today on the intersection between mathematics and COVID-19, including information on how mathematics learned in elementary to high school and undergraduate studies can be used to provide insights into real-world problems like COVID-19. At the end of today, we hope that the question, what is all this algebra, calculus, probability good for? We all ask all these questions when we're in high school, or we have heard someone ask all these questions. So we hope that this will be modified to, what real world problem do I want to study using my current mathematical skill set? This could be questions like, what is the most thrilling roller coaster at a local theme park? I mean, all of us, be it when we were kids or having kids or as kids, we have gone to theme park and we want to choose the best roller coaster. Or it can be, can recycling programs be optimized? We're all interested in helping our communities get rid of the toxic substance in our environment. So having a being able to optimize the recycling program will help our community and our city council. Or finally, what is the most efficient way to reduce the spread of COVID-19 or other infectious diseases in our communities? We will be recording this conversation, so please turn off your videos if you prefer not to be on the recording. And again, as Kumar already said, my name is Jude Kong, and I'm one of the moderators for tonight. And I'm excited to be joined by my great colleague, Jen Heffernan.
Hi, thanks Jude, and thanks Kumar for the introduction. And we'd also just like to thank all of the other sponsors for today's event. I am going to share some slides now, and I'll introduce our 4 panelists. So let me share my slides. Okay. So can everybody see that? Okay. So today we're going to be hearing from 4 panelists. The first panelist that we have is Dr. David Buckeridge, and he is from the University of McGill. He is a Canada Research Chair, and he also is an epidemiologist and an MD. And I'll let him introduce himself. David?
Thank you very much, Jane, and it's a pleasure to be here and part of this panel. Just a quick slide to give you some background to myself. I work primarily in informatics, data science, and health systems, the intersection of these 3 areas. So in the usual world before COVID, I guess, I had 3 kind of types of work I did in terms of practice in the healthcare system, providing advice to different bodies, and conducting research. And those kind of roles have continued in the pandemic. However, I've taken on some new projects. And so you'll be able to see a couple diagrams there of some of the work that we're doing in the context of practice. So the top left there, you can see the plot of us showing the projection of the demand for hospital beds here in the province of Quebec. And that's something that we're doing for the province of Quebec using mathematical modeling disease transmission combined with different Markov modeling strategies for how long people will spend in the hospital once they're admitted. And that not to brag, of course, but that plot showing our projections with the actual real observations in gray on top. And so just to show that we can do a fairly good job of predicting a number of weeks how many cases we're likely to have in the hospital, which has been very helpful. And so that's sort of, if you will, math and science in action there. And then also doing some research in this area. And the other diagram you see underneath there is showing you some initial results from the work we've been doing in conjunction with partners in the Public Health Agency and the World Health Organization around using machine learning to look at large volumes of online media data from different news sources and other sources to try and detect when and where different public health interventions are being put in place to control COVID-19 around the world. And so that's a research project funded by CIHR through the Canadian Institute for Health Research, through their, some of the funds they've mobilized to support COVID-19. And so this is sort of my role, sort of situated really in this area where we try and take these kind of modeling strategies and we apply them in real world settings and then try and generate insights that either can advance the actual decisions made right away or really our understanding of how different actions are being effective or not in terms of controlling the spread of disease in the population.
Thank you, David.
Okay.
So I hope that everybody is starting to think about some questions and they can start asking in the chat while we move on to our next panelist. Is Dr. Colijn from Simon Fraser University. And she is in the math department and is a Canada 150 chair. Carolyn?
Hi. Do you have my slide? Are you going to pull that up or should I try to find it and share it?
I have it. I have it.
Great. Okay, so I focus here on my COVID work. My broader research group before COVID, we look at infectious disease and we use math and we build math tools to understand infectious diseases better. Before COVID, I was mainly focusing on using genome data, so sequencing pathogens and building those data sets in together with the other data, the usual kind of case counts and timing to understand transmission. With COVID, especially, up until now, and maybe this will start to change, but right now, I think most of the information about transmission is not in sequencing and high throughput technologies like that. It's really in case counts and how we understand transmission. So what we're doing is using mathematical models to understand the data we have about COVID-19 and also to forecast what might happen depending on changes in what we do. So do masks, where do masks work? Where do strict bubbles work? Why distancing? Where does distancing work? So we think through those things in terms of events, like what might happen if you have a distinct event, And we also use forecasting, and on the screen there's one I did last week for BC with public data, just showing, where we're likely to end up if we continue in the direction we are headed. And in BC, that unfortunately right now is exponential growth. And it looks big and scary. And so we think about forecasting case counts using mathematical modeling. And we also think about using fairly simple conceptual models to understand how we might stop transmission and which interventions are likely to work best in which kinds of events.
Thank you, Caroline. So I think now we'll move on to Dr. Ashleigh Tuite, who's an assistant professor at the University of Toronto. Whoops. And she has been working quite closely with Ontario and with the Public Health Agency of Canada. So Ashleigh.
Thank you so much. It's a pleasure to be here today. So I guess in terms of my background, I am an infectious disease modeler and an infectious disease epidemiologist. And, more generally, pre-COVID, really interested in how we use models to improve how we make decisions. And also how do we communicate sort of that decision-making process. So how do we understand why we're doing certain public health interventions? And really interested in sexually transmitted infections and vaccine preventable diseases, as well as the role of population mobility in emerging infectious disease outbreaks. During COVID-19, I think very similar to Carolyn's work, I've been doing a lot of modeling on trying to predict the pandemic trajectory in the Ontario population. And beyond just that predictive work, which is probably less of an interest to me, it's more around sort of understanding interventions, understanding the implications of interventions, and understanding how we can use different public health measures to try and wrap our arms around this pandemic and think about how do we control it in a way that considers not just the health effects, but also the broader societal and economic implications.
Thank you, Ashleigh. Okay, and last but not least, we have our representative from Atlantic Canada, from the University of PEI. We have Dr. Javier Sanchez.
Okay, hi. Thank you, Jane, and thank you everyone for being here. I hope I can share some of my expertise and answer some of your questions. I'm very happy to be here for many reasons, but the main one is as a background, I'm a doctor in veterinary medicine, so I just maybe have a different perspective of how to deal with outbreaks and diseases, given that we deal with this, not this level of pandemic, but many outbreaks and diseases in animal health, and we can apply some of those concepts for other infectious diseases. So I guess I'm originally from Argentina. As I say, I did my training here in Canada, and I'm currently a professor at the Atlantic Veterinary College. But before that, I joined and did some work for the Public Health Agency of Canada and the Canadian Food Inspection Agency, and other kind of work related to disease modeling and risk assessment, and mostly related to, as I say, animal diseases like avian influenza, foot and mouth disease. We've been involved with some kind of diseases that have the potential to transmit from animal to humans as a H1N1, and we did some work at that time working closely with the human colleagues. Particularly here with COVID-19, our role was trying, based on the skill that we provide and we have, or the expertise that we have at the Atlantic Veterinary College, we were approached by the local government to support their epidemiologists in terms of developing some capacity in terms of infectious disease modeling and particularly for COVID, in terms of, at the beginning was mostly looking at what could be the impact in the healthcare system here in Prince Edward Island, and that's where we start getting more involved. And I guess the main focus on some of the research project that we have now is more on the post-pandemic situation and looking at surveillance data and how we can use that information for early detection and be sure that we have enough confidence there that we are free from this virus in the population. So that's kind of the main focus of some of the work that we're doing. And as being from South America, we also are quite involved with a group in Colombia for similar kind of thing that we're doing here in Canada, just to provide strategies to deal with this pandemic there in the country, and in terms of interventions that can be in place without looking at just putting into perspective more the economics, given that the situation there is quite different than here, and people cannot be in quarantine or off work for many months, and so it's just it's a different context there that we're trying to help them.
Okay, thank you very much. So now we have introduced our 4 very important panelists for the Café. And before we start with other questions, I'd just like to ask the first question. I know when I was in high school, I liked math and I liked computer science and health. And I went to my guidance counselor and I said, I'm thinking about going into mathematics. What can I do with math other than teach? And I was told that I could be a pilot or an architect. And so I decided, well, I didn't really want to be a pilot. I love to travel, but I didn't want to be a pilot. And I like looking at house plans, but I'm not really interested in architecture altogether, really. And so I decided to go to school to be a math and computer science teacher. And it wasn't until my last year of university that I took a course in math modeling. And that's what totally changed the direction that I was going to go into, and the reason why I'm in this field today. So I'd just like to ask the first question to the 4 panelists is, how did you come to work in the field of infectious disease modeling? Do you want to start, Javier?
Sure, yeah. It's a great question, and I guess I have a different background. So my interest when I went to the counselor would say, I always say I like animals, and they say, why you don't study veterinary medicine? And I stick to that. So I went from the biology, and then I was pretty much interested in, I always like numbers. And I guess when I decide in my veterinary medicine background or training, I like the idea of population health. And that's kind of brought me into some of the metrics, more into the math and probabilistic type of model of how to deal with numbers in terms of getting from what happened to one individual, how we can translate that into a situation in the population. And that's where I guess brought me into more deep understanding of math and calculus and that kind of things. And that was always my, in my training, is always trying to keep that link and the perspective of how much of the math I can use for my biological problem without losing the initial question that I want to address at the population level. So that was kind of my connection. I in terms of the biology or the health and the math, always trying to use this infectious disease model or statistical model or some kind of quantitative approach to address question at that level.
Okay, let's go to Carolyn.
Yeah, I think it's a great question. And indeed, we kind of don't always communicate all the uses and applications and amazing things you can build into with math when we teach math. And I think maybe we should start to do that. And maybe this is part of that. I started out in physics, and then I moved to physics math. And then I really wanted to broaden out. I always had really broad interests. So I did a master's degree in environmental studies where I looked at social change, and I had this idea of scale between very small scales and very large scales. And then I studied quantum theory for a while because I was really interested in these very small scales. And then it was as a postdoc when I started doing mathematical biology, and I got into infectious disease modeling when I worked in a TB research group. And I noticed there that the kind of classical tools mathematicians were using weren't always able to answer the questions that TB researchers and epidemiologists had. And there was really a need for new mathematical tools. And that was really exciting. And that's when I moved into infectious disease modeling and particularly started thinking about diverse infections, drug-resistant infections. How are they competing with drug-sensitive infections? How can we model some of these evolutionary questions that are happening when we select for resistant strains using antibiotics or when we change our behavior? And so that really got me, the need for new mathematical tools and the availability of data, which frankly in quantum theory is much harder to come by. And the public health relevance really got me hooked in the field. I think it's a great field.
Okay, thank you. David?
Yeah, so for me, I guess I started with more of a computer science perspective. That goes back to grade 8, I think, when they forced everybody in my school to take home ec and computer science. I can't remember anything, but I was hooked at that point, and then did some work in biochemistry and computer science in undergraduate for going into medicine. But I didn't really come back to kind of this sort of modeling until I was doing my PhD work, which is really, again, more from a, as you saw from my background, a bit more from a health systems and monitoring perspective. And we were trying to understand, how do you build systems to detect and track disease epidemics accurately? And it turns out, going back to the data point, there wasn't a lot of great data around to really evaluate those kinds of systems. And so we got into simulating epidemics and to try and understand, how we could generate data that could really, in a robust way, evaluate the characteristics of systems meant to detect and track these kinds of conditions in populations. And so that was my path, a little different perhaps than folks that are really more focused principally on the mathematical modeling piece, but really coming from more of an applied perspective and using this kind of infectious disease modeling as a way to build and test our computer systems that are meant to monitor these kinds of epidemics.
Okay, thank you. And Ashleigh?
Okay, so I always feel like a bit of an imposter at math events. I liked math in high school. I was good at it and never really thought of it as something that I would use beyond calculating my grocery bills and figuring out, my expenses. I did my undergrad in biochemistry and did a master's degree looking at the genetic basis of susceptibility to infectious diseases. So I was working in a lab and realized that I didn't really like doing the experiments. I really liked doing the analysis. And so I worked as a lab tech for a couple years and kind of discovered epidemiology. I didn't really know it was a thing, which is kind of embarrassing to admit. But it just wasn't something that I heard about in high school. You hear about teacher engineering and, sort of these very traditional career paths, and nobody in my family worked in health or in medicine. So I went back to school to do my MPH in epidemiology, and that's where I discovered infectious disease modeling and really fell in love with it, and ended up doing my PhD in modeling, looking at using models to understand the syphilis epidemic that was happening in Toronto and continues to happen in men who have sex with men. And that really was my introduction into that world. So I think, my perspective is more as somebody who has a health sciences background and more of a sort of biological background, but who uses modeling as a tool to try and answer questions and understand the world.
And I always think that in the field of infectious disease modeling, there's always all those different avenues that people can take to get into the field. And the field is so broad that you can come at it from a more computer science or a math angle, or come right into being focused on interested in this particular disease or this particular characteristic of different diseases. So I always love going to math bio conferences and disease modeling conferences to really have these really rich discussions on how people got into the field. And I'd just like to thank everyone for telling the audience, all the participants, all the different ways, because I think we all represent different ways that we can get into this field. And it can be an early interest or it can be a late interest. I just think it's always interesting being a lifelong learner. Okay, so I think that we'll turn over to some questions that are coming on the chat. Jude, do you want to ask some that are coming in on the chat?
Yes. Okay, let me look at some of the questions that are here. So there's a question here on, let me just ask one of the questions that was asked here earlier on by one of the participants earlier on. So the question goes thus: do you agree that epidemiology models are useful for qualitative understanding, but not for quantitative predictions? According to this view, models can give us important insights, not the evolution of an epidemic, e.g., the overall shape of the curve, but we should not rely on the specific number of infections, deaths, etc., predicted by the models, because it is very hard to get the numbers right, even within an order of magnitude. So I will start first with Ashleigh.
So I would say I agree and disagree. In terms of my perspective, I'm not a huge fan of the predictive modeling, just because I think that the challenge with predictive modeling, when you're talking about longer term predictions, I think we can do with, fair degree of confidence, shorter term predictions. I think the challenge when you're modeling a communicable disease is that you have to capture human behavior. And that's a huge X factor. And I think it's the one piece of this that is the hardest to predict. So when you have an infectious disease, and we're seeing this with COVID right now, it's really, really hard to predict how people are going to react to it and what the effect of individual behaviors is going to be on the transmission of disease. So, if we were in a world where we understood human behavior, I think we would be in a better position to be able to say with confidence that, if we do this particular intervention in a population, this is what the outcome is going to be. But I think at this point, we just don't have the knowledge, and my other panelists may disagree with me or may think that we're getting closer to that. But I think, when you compare infectious disease models to weather models, the thing with weather is that if I go out and take my umbrella with me today, that's not going to affect whether or not it's going to rain out. With a communicable disease model, if I take different measures, if I start washing my hands, that's going to have impacts in terms of disease spread. And so I think that's the real challenge with trying to have really precise quantitative estimates, is that really sort of the human behavior piece of it.
Thank you so much, Javier.
Yes, I guess I would agree with Ashleigh somehow. I think one point I want to make in terms of the use of this model is rely on what she said in terms of knowledge, and I think it will depend on the information, the amount of data that you have to use a model for prediction or just to assess the level of efficacy of intervention. And I think for COVID, there is a huge uncertainty, and uncertainty is just we don't know much about many things there, and we're making many assumptions. So that will affect the use of the model in terms of prediction in the long term, and that could have a tremendous impact. Basic information that we usually have is just to compute proportions and that kind of thing, and the denominator of that simple equation is mostly lacking in many situations here in COVID. So just to compute simple prevalence estimate, we just have no good understanding of how things are occurring in the real world. So just to make a complex model to make prediction with little information is where we can have this order of magnitude that could be very different across different models. So I think it's just we need to be careful and we need to know the data that is going into those models in order to use them accordingly. And but doesn't mean that we cannot use it. I think that it's just the decision makers need to understand some of that go into the model in order to make proper decision. And in animal health, it's happening the same, and we have plenty of evidence of trying to use model during an epidemic and changing the course of action based off if a farm in a given location is going to be infected or no, and that is not good use of the model. So I think the question in terms of a qualitative and interpretation for a quantitative model depends, and it depends of the type of question and the level of information that we will have in order to make that, to create the output.
Thank you so much, Javier. David?
Yeah, I'm wondering if David and Caroline, when they're talking to, they can talk a little bit more about the limitations in the data that we have been able to use.
Sure, I don't have a lot to add. I would just point out or reiterate, I think there are many types of models and they can be used for many purposes. And I think perhaps the most important aspect of this question is, what's the purpose and also maybe more what's the time horizon? So for example, the slide I presented, here in Quebec, we are using what's called a semi-mechanistic model, which is really based a lot on surveillance data to do an initial projection over a very short period, over 4 to 6 weeks of what we expect to see. And then that feeds into another model that allows us to then think about what's the demand going to be in the healthcare system. So, we purposely kept that horizon very short because of all the reasons that have been raised already about how it's very difficult to predict the dynamics in the future. But, a lot of it also is, for those kinds of models in particular, as you were saying, Jane, is the challenge is the data. I mean, the data are there, but we have data measured in different ways on different things, like cases, but, cases for COVID-19 are all often influenced by your testing policy, not really the spread of the infection in the population in some, sort of fundamental way. And then we have hospitalizations and deaths, but again, there are accounting problems with how you do this. And so part of the modeling becomes also how do you squeeze all the juice you can out of those data in a sense, and not looking at them one at a time, but trying to think, how do I use math and statistics to understand the linkages between those data so that even though I've got a lot of imperfect data, I can kind of pull it together and get some sound, inference out of it. And as I said, this kind of horizon issue for us, we're really given questions from people that are running hospitals and health systems, and they have to make decisions. And so then you kind of come back to the point, yeah, there's uncertainty in where we're going with this, but as long as we can, do a decent job and communicate the limits and the uncertainty in what we're doing, certainly that's better than people having to just make decisions with nothing. And so that's kind of that sweet spot, how can you provide advice over what kind of horizon, what models, what data, without being misleading? And so I think that's kind of a challenge as well in this area.
Thank you so much, David. Carolyn?
Yeah, I don't want to add too much either, because I know people probably want to move on. I would say, I'm going to come out in favor of forecasting. And I don't think models can predict human behavior but I think they can be used to show where we're likely to end up if we continue in the direction in which we're headed. And so if we don't change our behavior, we can estimate our behavior today and over the past weeks, and we do this using our favorite model. And you can do it using your favorite model too, and you'll probably get similar things because all these models show exponential growth or exponential decay. That's what they do. And we can say if we don't change our behavior, this is what's likely to happen. And we can estimate if we change our behavior a lot, this is, we need to change it a lot in order to have an effect, or we only need to change it a little bit in order to have an effect. And we can try to describe and visualize some of that uncertainty. And I think that can help policymakers see that big wide ribbon of cases that, could be low, could be high, but in the middle, it's sort of not looking great. And I think that can inform planning, and models can also help us run experiments that we can't run in human populations. We can't take 2 towns and say, in this one, we're going to reopen everything. And in that one, we're going to keep everything completely shut down and see what happens. We can't do that. We can do that in models. And so I think models are a good resource. They're not crystal balls. I think we can use them for forecasting while recognizing that they're not crystal balls that predict human behavior. And we can try to use them to understand what the answers are sensitive to and how sensitive they are to those answers, and try to communicate that information visually and really clearly.
Thank you so much, Carolyn. In line with what you just said, which is really important, and I will not be emphasizing on that because you guys have actually stressed much on that. There's a question here from Nina Asidena, who tried to look at how that will actually cost to certain group in our communities, because most of the models generally generalize the entire population as a whole. And so Nina asks, I'm wondering how one can make sense of a model that can optimize the cost in regards to long-term disorders effects to a risk to at-risk groups, as well as the short-term gains that influence Canadian populations at large. Notice that this is not mutually exclusive to the first effect, because immediate effects are seen in these groups as well. Take education, for example. From a health perspective, social distancing will benefit Canadians at large. But on a long-term perspective, online learning has a negative effect within certain demographics. I'll start with Carolyn, if that's okay.
Sure. I mean, I think those are such hard questions. And a lot of us haven't focused on modeling complex, long-term direct and indirect costs, because it adds another massive layer of uncertainty on top of the uncertainty we already have. So someone on the chat has brought up asymptomatic cases. That's an area of uncertainty, and undetected cases is another area of uncertainty, as David mentioned, the ascertainment, like how many people are we testing? Who are we testing? When are we testing them? How many cases are we catching? What's the base population? There are all these things that are pieces of the jigsaw around interpreting the confirmed case data. And then once you add to that, what are the impacts on education? What are the impacts on, different groups and with different risks and different outcomes? And what are the costs? Cost effectiveness analysis is a whole area in healthcare, and it's hard to do. And so I think we haven't, at least I haven't in my group, focused on the cost analysis and the bigger picture analysis. I know there are economists, and probably some of the other panelists are thinking about these things, but from my point of view, it's just hugely challenging. And I think we need to learn how COVID is affecting groups, and then use, if we can, relatively simple models, but it's very hard to predict. And I think you can model it, but you'll get out what you put in, because you have to make so many assumptions to model it, that you may not learn a lot. You may learn a lot, but you won't be able to really estimate those costs too accurately. But I think other panelists may have better information about those.
Thank you so much, Carolyn. Javier?
Yes, I would agree with Carolyn. I guess I'm no economist, and although we have one project in South America working more on the economic, it's more looking at the direct effects of the interventions on COVID. But I think this is the whole dilemma of COVID. It's a hard question, I agree, to answer. It's the whole dilemma of COVID. Is what is the balance at the end, is in terms of the economic consequence or the health consequence. And even if it doesn't look good to talk about number when you put lives there in question, but the number of people being affected, when we talk about mortality in the population, even it's difficult to quantify when we have an estimate of how many people are being infected today. But the proportion is very, very small. So some of the intervention, I agree with the learning piece, the education piece, it can have a tremendous consequence for the young people coming after us. And that's gonna be difficult, I think, to quantify, but I think the impact is being observed right now in many countries around the world, more with the indirect effects than the direct effect of COVID. So interventions that are in place are going to save life, are going to save the high risk groups, and are costly. But the indirect consequence of that, I think I haven't read in detail any work in terms of numbers of those indirect consequences, but I think are going to be in much larger scale than the direct consequence, for sure.
Thank you so much, Javier. David, in case you want to add more to that.
No, I've got nothing to add. So in the interest of time, I'll skip to the next panelist or question.
Ashleigh?
Yeah, I mean, I'll just say quickly, I think it's a huge challenge for infectious disease modelers, because we tend to think about health outcomes as very direct health outcomes. So, you get infected with the disease and you are a case and you get hospitalized, and, if you die, there are costs associated with that. And if you get hospitalized, there are costs associated with that. But this is such a complex and far-reaching problem that, you have to think about the costs of, not working, the costs of being home from school, the costs on productivity to parents. So I think that, even a traditional health economist, trying to tackle this question is struggling right now because it's just so far reaching, and we don't really, I don't know that there's a model or a system in place that I can sort of look up and point to that says, we've been able to sort of capture this larger complex question around, what are the trade-offs sort of societally for taking different paths in terms of how we respond to this pandemic. So I think it's probably an area of research that's going to, develop very quickly, and we're going to learn a lot over the next year or two as we start figuring out how do we tackle this, and who needs to be at the table when we come up with a model or a solution to try and answer these sorts of questions.
Thank you so much, Ashleigh. I would like to remind all the elementary school, high school, junior high school students that are present here that please feel free to come on mic and ask your question. We'll give you room to actually speak out, be able to ask your question as to the motivation. And thank you so much for the cost in respect to communities around our neighborhood and actually explaining in a very in a way that I couldn't have explained. I'm seeing another question here from Stacy, which is kind of related to that. Stacy Juvek is asked, how is COVID unique from other epidemics in our history? The reason being that this question seems interesting because a lot of our politicians in our communities have argued that COVID is the same as flu. Why do we pay a lot of attention to this? The cost to the economy, people are staying back home. So I'll start with David and try to find out how he thinks that COVID is actually unique from other epidemics in our history. David?
Well, that's an interesting question. I mean, it's an emerging infection, an emerging disease. So, we've only really known about it for a few months now, I guess 6 or 7, depending on how you count, maybe 8, depending on it. Clearly there are other similar viruses we can learn from, but there are a lot of really new and unique features about this particular virus. And this rate of spread around the globe is really unprecedented, I think, or as far as I know, in terms of pandemic. And so, I think that's the difference really, is the scope, the extent, the speed at which it's spread, and the fact that we're really learning everything almost on the fly. I mean, apart from the analogies we can make. And I think there is even kind of a link back to the last question too. There are other pandemics, and there are others like HIV, so on, that we've been struggling with for many years and still don't have under control. But this one really came up and spread so quickly, and has had such a massive impact across all sectors of society in all countries that it's kind of unique. I think if we think more specifically about respiratory infections, this ability to transmit this infection without clear symptoms is probably the biggest single thing that's making it really, really challenging to control from a public health perspective. But those are the ones I think, in my mind, that are really the unique aspects of it.
Thank you so much. Ashleigh?
Yeah, I mean, I think the challenge, or the thing that's unique about COVID, is that, if you look at the pandemic plans that are in place, I think the assumptions, in terms of what the disease would look like, are not at all what COVID has been like, in the sense that, it's not the flu. It's not the same as SARS, in the sense that, most people don't get very sick. I think the thing that's really thrown us for the biggest loop is the fact that people are transmitting when they're either pre-symptomatic or asymptomatic. And so, as we sort of are, and I think this is a unique time to have a pandemic, in the sense that, we're all learning together. I think, people who are on social media are probably, very, very aware of, the rate at which we're learning about this, and the rate at which, there's so much discussion, and it's confusing. Like, I mean, I was having a conversation with a colleague yesterday where it's like, everybody seems to have very clear ideas about how this disease spreads, or how transmission works in children, or how the pre-symptomatic transmission works, or how aerosols versus droplets. And there's all of this sort of information that's being generated, and we still don't really know. I mean, I think there are people who think that they know, but I think, in the coming months, if we look back on this, we're going to have, a very different understanding of the virus and how it transmits than we do today. And I think that's why, there's the response has been the way it is, because we're sort of course correcting as we understand more and as we learn more. We're you know, the initial response was, you know, this is a pandemic disease, shut everything down and let's learn as much as we can. And, you know, as we're starting to understand that it transmits better indoors versus outdoors, we're sort of modifying how we respond to it. So I think it's, you know, the reason that it's been, I think, frustrating for everybody as we sort of go through this together is that we don't really know, we're learning. And so that's been the challenge.
Thank you so much. Carolyn?
Yeah, I think that's right. I think we don't really know. I think the fact that this is a zoonotic infection, that it hasn't co-evolved with humans, we haven't been exposed to it a lot before, is one of the really big differences. And some of our pandemic preparedness planning has been around flu, because pandemic flus have been a problem for, you know, for centuries. And so that makes a difference in the dynamics around kids, and that's among all the zillions of things we don't know. One of the most topical ones right now is about schools and kids, and are kids infectious? How infectious are they? Are studies saying they do have a high enough viral load. There are other studies saying they haven't infected others in their households as much as adults have. We haven't exposed them very much because schools haven't been open in a lot of places, and now we're heading into September, and where places schools have been open, the data are kind of mixed about what happens in schools. And so there are lots of uncertainties, but I think one of the big differences between this and past pandemics is adults haven't been exposed as much to related viruses, and so the elderly are very at risk, and the immunology is a bit different than it is with flus, and also the uncertainties around kids and whether kids are a big driver. We know with flus, kids are a really big driver, and we just don't know that here, and so that's, you know, along with all the other uncertainties, I think that's a big one.
Thank you so much. Javier?
Just, I guess, for time reason, the only thing that I'm going to add is in the question of similarity between COVID and SARS, that I guess we believe that both of them, I guess we have more evidence in SARS that the origin was from an animal source. I guess there was some, on COVID was kind of indication in the same direction, although still some literature that kind of argue about the origin of this virus, but I guess was a paper or a scientific publication in 2007 that indicated that we're due for a coronavirus pandemic. So it was coming, it was predictable. They were looking from the virus perspective, and the evolution, I guess, of these changes in practice and human density and how close human get into wild animals, and they were predicting that we're going to have this virus soon. And in terms of other difference, I guess we have other virus, like is the Middle East coronavirus. That is a much higher fatalities. When you get infected, you are much more likely to die. With coronavirus, with the COVID, is I guess as it was discussed, is the characteristic to spread so quickly is because we have the perfect storm here. We have a virus that doesn't affect in great level to individuals, and people are traveling all over the world. So when we see those maps of people going from one part of the world to the another in 24 hours, we got the perfect combination. So the virus was able to be able to survive and adapt to that kind of condition. And I think that by the time that we were aware of this situation in China, you gotta see all the flights coming from that province, not the direct flight, but the indirect flight. It wasn't gonna take long to get the virus across the world, and that's what's happening.
Thank you so much, Javier. At this point, I will pass over to my colleague, Jane, to continue with the question. We have a lot of questions, and I would like to acknowledge that we may not be able to answer all today, but we'll provide answers to all the questions at the end. Thank you.
I know that we do have a hard stop at 1, and so we're going to have the last question very soon, but I would like to reiterate too that you can ask your questions on a post-survey of the event, a post-event survey. We're also going to have another event in September or October with some different panelists, so you'll have some time to ask different questions then, and you may even in the post-event survey be able to advise on what topic you would like the next cafe to be on. So for the second last question, I'd like to introduce Georgina Spence, who can turn on her video and ask the question.
Hi, I'm an undergrad. I'm Georgina. So given the existence of undetected cases, how can you really create an accurate model? Because from my understanding, a standard SEIR model would require knowing how many people are exposed or infected, but asymptomatic carriers who aren't going to think about getting tested because they're not coughing or sneezing. They would really make it impossible to accurately model the amount of infected people in a given population. How do you get around this in creating models?
Anyone want to go first? Carolyn?
I can do that because we work on this in our modeling and forecasting. So what we do is the model imagines that there are people, of course, some of them are asymptomatic, some of them are symptomatic, some are going to be symptomatic, maybe some are not. And then we make assumptions based on other data that's not in the model explicitly about how many of those people there are, like what the portions are. And then we imagine that, you know, let's say somebody becomes symptomatic today. Not everybody infectious will become symptomatic, and they'll do it at different times after they've been exposed. But if they become symptomatic today, there's some distribution of time until they get in the reported data. So maybe that's 4 or 5 days later, or hopefully not, but maybe it's 10 days later, or maybe it's 1 or 2 days later. So we fit the reported cases with this kind of imagined backtracking to what, you know, if you see 10 cases, there might have actually been 50 cases. And if you see 10 cases today, there might have been 50 cases, but they were over the past couple of weeks or maybe week and a half. So we build that into the model and use a likelihood to understand, you know, if there were 10 cases today, it was unlikely there were 5,000 true cases over the last 2 weeks, but it's also unlikely there were just 10. We've probably missed some.
I was going to add, if I have time there, it's a great question. And this is something that we deal on a daily basis because we have no information. But in terms of providing some tools, I would say, to the decision maker, this is the kind of, I guess Carolyn mentioned this, is for planning. And this is what we do sometimes. Is just as humans, we want to see what will be the worst case situation. So we provide these if scenarios. If the number of asymptomatic or the proportion of asymptomatic, which is a big unknown sometimes, was this number, 50% or 60%, this is how many intensive care individuals you will have in the next 4 or 5 weeks. But if the number of asymptomatic is only 10% and you're having a good system to track them down and reporting and testing, then this is the number of beds that you need in your hospital. So then the decision maker will have a situation where they can plan and say, okay, are we prepared for the situation where we have no information, where we have a high number of asymptomatic that will allow us to spread the virus quickly, and then suddenly we need 50 beds in the hospital. So the use of model is no more to have accurate prediction, but just to provide them with potential worst case scenario that they need to start thinking ahead. So it's just another tool for them in the decision maker making process.
Okay, I think I'm going to move on to the final question, and it's a very short answer that each panelist will provide, and it has 2 parts, and it's yes, no for both. The first is, has your model affected policy, or do you have collaborations that are helpful in translating your work? Yes, no. Yes, public health. And the other is the mathematics that you learned in high school, is it useful? Let's start with David.
Yes, I like to think so. We were mandated by the government to create the model, and they seem to be using the information to make decisions. So I'd say that's a yes. The second is an absolutely yes. You know, I think of, I mean, and I'm kind of like Ashleigh, I feel a bit like an imposter. I'm not a true mathematician, really. Like I think Carolyn, I'm more of a informatics person, but which is really more computer science and its application in healthcare. But everything starts with what you learn in undergrad, not in primary school really, but I think really in high school is really where it starts to pick up. And, so it really starts there. And not to go on too long, but there's so many things you can do as we discussed. So yes and yes.
Great. Ashleigh?
I would say unclear, but I hope yes and no. I mean, yes, sorry, yes, absolutely yes for math. Sorry.
Okay, Javier?
I would say maybe for the first one. I think help PI using some of the model for the planning. In terms of the high school, I cannot remember what I did in Argentina. I guess was focused too much in animal health and veterinary medicine.
Okay, and Carolyn?
Yeah, I would say yes and yes. We work multiple times weekly with BCCDC and also doing forecasting now for Public Health Agency of Canada. And I think the modeling, not just the one I showed, but I think it has influenced policy. And yes to the high school math. We can't do what we do with just high school math. I mean, there's no just, high school math is great. We need more tools, but you couldn't really get into this without some understanding of like, what's a function? How do you map cases to something, some likelihood function, or how do you understand, how to think about, how many people are infectious now without thinking about what's a function, what's the algebra behind it, and look at the calculus of how is that changing in time. Those are really fundamental things. And I think we couldn't do this kind of modeling without high school math. So definitely yes.
Okay, I'd like to take this time to thank all of the panelists for participating in today's Café. And I wouldn't be able to end any of this type of work or any of these outreach events by saying that York University has a mathematical biology program for undergrads. And so if you're interested in disease modeling or mathematical biology and working with epidemiologists or biologists, or even going into working in a network that includes Ashleigh, Carolyn, Javier, and David, please think about math bio, not necessarily just at York University, but I'm going to plug the program. I hope that you all had fun today for the panelists, and I hope that all of the attendees enjoyed. Please do the post-event survey so that we can answer your questions that we were not able to get to today. And please also inform us with what you might want the next Café to be on, whether specifically on another topic of COVID-19 or a more specific one or some other disease. That would be great. Thank you so much, everybody, and have a great day.
Thank you.
Thank you.